Hi, welcome to this week's lecture series, an article review on integrating dry needling into clinical practice. This article now, it's pushing 10 years old, but the foundational information that it has is still very valid, and it's a great article to really just give us that foundational knowledge in dry needling and physical therapy. Though, since you all have the notes from this, I am going to spare you reviewing some of the history of the early foundations of dry needling, but kind of knowing where it came from is a valuable thing for background knowledge. So I recommend perusing these notes and just getting a sense of some of the instrumental people in looking at dry needling and how it came about and how it's developed into its current model. Certainly the Travell and Simon's approach and their manuals were pretty instrumental in physical therapy and dry needling education. Let's make my screen a little bit bigger here. There we go. Definition and scope. Again, APTA's definition of dry needling is it's a skilled intervention using a thin filiform needle to penetrate the skin and stimulate underlying myofascial trigger points, muscular and connective tissue for the management of neuromusculoskeletal pain and movement impairments. It's a pretty nice definition, a little wordy, but it kind of covers the basis there of myofascial trigger points muscle. But again, I like the management of neuromuscular pain, the neuro portion of it too being a big component of it.
And then just to kind of
Myofascial,
go over, a couple key terminology. I think we went over some of this in probably hour one, week one. Um, but those myofascial trigger points are again those irritable spots in a taut band of skeletal muscle that if you compress it, if you stretch it or overload or contract it, then you're going to have a referred pain to a point distant from that spot. So Travell and Simons has a great amount of a great amount of referral maps. We have a couple in this presentation, and we'll try to make accessible a handbook with more of them. Um, in this case here, you can see, all right, some of those gluteal muscles. Hey, there's a trigger point up in the gluteus medius, gluteus minimus that can refer anywhere from that posterior glute max down to along the lateral leg. And so these can be, these are A, things to watch out for, and B, they're also needling targets. Hey, you might have a patient who's coming in with some lateral thigh pain that may or may not have a myofascial trigger point in that glute med or min. Active trigger points are those that reproduce their familiar pain with or without palpation. It can be contraction or some compression as well. And then the passive trigger points are those that do not cause pain except when you palpate it. Latent are, so you have this local and referred pain does not produce symptoms familiar to the patient when palpated. Um, but it's the typical person who doesn't really have any pain in a muscle, but you can find something that's a little uncomfortable.
yeah, and I've heard it both too, where the passive trigger point definition, latent trigger point, I've seen them used a little bit more interchangeably over
Hmm.
time. So as you see that, depending on who's publishing and who's doing it, like I've heard latent trigger points also being referred to as that doesn't cause pain except for when stimulated with palpation, needling. Here's some nice diagrams to kind of go through looking at, different muscle patterns when we think of referral points and how, again, how these referral points come about, generally through, their embryological or development. You'll see sometimes it may not match clearly like a radicular pattern. You're not really looking at the dermatome distribution of the same nerve. So there is overlapping area, and there's some thought of that as okay, is it more in the sclerotome, the deeper system, and how this pain refers into different and projects into different areas. It can be based maybe a little bit more on embryological development in that area. But it's where you get these distal referrals. And again, these referral points, they're not radicular in neuropathic pain, which would be what you would get from a nerve root compression or, a nerve root irritation or inflammation around it. This is more somatic, kind of nociceptive referral. I think you would be referring to this as versus purely, okay, I have an L5 nerve root that's irritated and it's giving me paresthesias into the L5 or region or lancinating or causalgic pain. So as we look at these pain points, it's good to understand quality of pain that's occurring in these referral points because you'll often sometimes with dry needling and stimulation, you'll often see like what they'll feel is like in traditional Chinese medicine, they call it like a day quai or a flush feeling. Sometimes refer into these areas as you're needling.
Yeah, I don't know if you have the hamstring in there. I had a patient recently where I was needling the hamstring, and
Mhm.
I was not near the sciatic nerve, and the pain that he felt was not, uh, you know, radicular or neuropathic in nature, but he felt that kind of that dull pain down the back of his leg, and it's just, hey, you're stimulating that deep referral pattern.
So, and it also goes to doing sometimes treating like, okay, you'll see with the needling technique is like, okay, understanding these patterns is, okay, where might I want to be treating elsewhere? Because you'll see here, let's say for instance, we're looking at, okay, subscapularis here, where it's the back of the arm, posterior shoulder, certainly a hot spot. We may see it up in there, all down along the wrist. These are classic spots that may be referred to. Now, every wrist patient, I don't go up and needle the subscapularis you know, what you're going to find is that you may get these referral where there's this achiness into that region or referral into that region. Your primaries you can see are more localized to the region you would expect them, with the secondaries as being more of a peripheral referral area. I would be aware of them as you're dry needling, in these spots because you may notice that hey, they get a flush or a distant feeling. You many times may be looking at this, or you're patient who's having, wrist or shoulder discomfort may have scalene or pectoral, I think their pectorals are tight. We're certainly going to look at the scalenes and everything in that region that may be involved in there as well. So it's just a nice to understand that, hey, there are these referral patterns, they exist. We look for them certainly within people that we're seeing but it's not atypical to see there like that levator scapulae pattern is fairly typical in what we see. Certainly rectus capitis, posterior major, posterior minor, and referral pattern too. It is probably a bit of overlapping because the relationship between the attachment of the rectus capitis, posterior major, and certainly levator scapulae, all having an influence in that upper region.
So I think it's important to prepare and think about, you're going to inevitably have conversations with patients when you bring up the possibility of dry needling of, oh, is that acupuncture? And I think it's good to kind of have just a little bit of a vocabulary. Um, as we've been talking about, dry needling uses this Western medical model based on clear anatomy, musculoskeletal anatomy, and neurophysiology. So there's distinct targets where we're going after structures to affect these neurophysiological and mechanical local effects. Um, Acupuncture, on the other hand, is based in the Eastern medicine, has been done for thousands of years, has some great evidence. But the basis of it is on that meridian theory, and the energy flow for their treatment approach, and is not as reliant on actual, you know, medical models. They also tend to go much more superficially, as opposed to dry needling will usually go a little bit deeper into the muscular area. Now, both have an impact on the nervous system, peripherally and centrally as well. So I think it's, hey, same needles, but that's about the only thing that really links the two. Their aim, their target, and the philosophy and model is distinct.
Mhm. Yeah, and that's it. Is that the approach being somewhat more local. There's a central response, and those central responses, that happen in the central nervous system will overlap, but the approach is significantly different in philosophy and scope of practice. And kind of getting the scope of practice, we looked it up and updated this from the 2015 article, using data from the APTA website is, roughly 38 states plus DC allow dry needling. Those may include some states where the law can be quote unquote silent. And the silent state is the one that has no opinion on dry needling or no statements. And those where it's generally considered to be, those states generally considered to be that it's permitted because they're not being told that they can't. Just kind of a traditional, almost even a, athletic training model of that too, is that their practice act did not, exclude it. So many times they took that as it's within that scope. Again, that's no opinion on it one way or the other. It's kind of what I've generally seen over a period of time. Federation of State Boards of Physical Therapy, released, for released a resource paper back in 2015, just kind of defining the scope of dry needling and within physical therapy practice and the knowledge and attributes and skills that should be involved in it. And much of what we do in this training too is to cover a lot of those areas as far as safety and concern and patient awareness and scope. APTA and AOP also issued position statements, supporting physical, PT and the use of dry needling over this period of time. Educational requirements, not typically taught entry-level PT education. And that was at the time of this article, though. This is really changing. Many states, are looking at, this getting into the curriculum there. And some states are starting to recognize it. Like for Maryland, for instance, now is looking at, hey, are they looking at changing their requirements to allow physical therapists at entry level meet the requirements, the needle in Maryland. So again, no opinion on that either way, but just know that okay, typically it was not entry level, but as our practice evolves, we realize that hey, this is probably something that can be taught very competently to an entry level physical therapist as we gain more data and we've got years of practice under our belt. And in states like Maryland, they're looking at that as well as other states where there isn't the immediate requirement. You know, most states do require some level of postgraduate certification or continuing education. Again, some of that is being rolled now into the PT primary education at entry level. And again, as we talked about, the FSBPT task force, amongst other ones, also established, just competency standards and safe and effective clinical needling practice, which again, if you have this paper document, I included the link above to that paper, which I did not see an updated version of it when we went to kind of create this document. Here's a nice colorful picture of, dry needling. This was taken from the APTA website. Has a reference of states that allow dry needling and those that exclude it. Those that have prohibited PTs from doing it is California, Hawaii, New York, and Oregon. Oregon's an interesting state because there was almost a bit of a trade-off for manipulation, I believe, if I remember the story correctly, is that they traded, basically dry needling for manipulation. I believe that's what it was. It was a bit of with the Cairo organization. So I know there's something funny with Oregon when this came down. But I expect that those states with a large amount of evidence should be probably reviewing those standards if they come into more line with what's more acceptable.
And in terms of the teaching philosophy, I think, we've tried to echo this in the first couple weeks. Um, in general, dry needling should never really be done as a standalone treatment. It's the evidence out there that is on dry needling alone. It's kind of tough because it doesn't really it's that's not really what it's best at. It's really best when it's integrated with a comprehensive multimodal plan of care. So true diagnostics, good manual therapy skills, loading of tissues and building up of functional capacity. As we have mentioned before, needling addresses those peripheral neuromuscular drivers, but we really need to have that functional carryover, and that's going to be provided through motor retraining. So hey, after you do some needling, if you're working on some neuromuscular drivers, do some light load movement pattern retraining to really help cement that in the higher brain centers.
Makes great sense. I mean, if you're trying to down ramp a sternocleidomastoid and you've chosen to needle it, then right afterward, your deep neck flexor exercises and your neck movement patterns, which down train sternocleidomastoid, upregulate longus colli, longus capitis in the deep system, is certainly appropriate. It would certainly be appropriate, if I was manipulating the cervical spine just as well to do that. Same thing if you're trying to down ramp of like let's say rectus capitis inferior oblique, and again if you're doing the cervical section, you chose to needle some muscle like that. Certainly working on head, craniovertebral rotation and craniovertebral flexion motions would be appropriate. Likewise, hamstring, as Frank alluded to earlier, I would look at eccentric loading and lengthening type exercises. Can I get them to comfortably lengthen and control? you know, Passive is fine, but I want to basically get that neural input into the brain to know that, this I can control and lengthen this muscle, for better function.
So the goal for needling is not just pain relief, but it's also that, there's optimal movement patterns. If we have excess trunk stiffness because of erector spinae firing, hey, can we decrease that? Can we up ramp multifidus activation and then move in a functional way, and build up that functional capacity. One way I think about PT in general is that we kind of have two goals. Is number one, over time increase the patient's and each of their tissues functional capacity, and in the short term limit how much we use so we don't overload them, take them past their current capacity. So needling is a great adjunct for that. And then the other big thing is that clinical reasoning, you really have to drive the selection of techniques based on the patient presentation, irritability, tissue reactivity, patient beliefs, patient apprehensions. You can't just, you know, pick a muscle and just go at it just because you want to go at it. It's really has to match and be tied to strong clinical reasoning. When we think about tissue irritability, this is a
Irritability
great
is
um, chart. You think about low, moderate, and high. It has some breakdown of pain level, pain at rest, pain with active and passive range of motion, and any kind of functional disability. This can be a good framework on which to consider dosage for dry needling, manual therapy, loading, really a lot of our modalities and treatments. If you have somebody who, hey, we're talking about the levator scapulae, and they have super high irritability, so they're having trouble sleeping. There's pain even with early range of motion, and their pain is 8 to 9 out of 10. I'm gonna do likely only a few needles. I'm likely not going to do stim at first. It's going to be kind of superficial. It's going to be short duration. Um, so, similar to, hey, if you had a biceps tendon that was really, really irritable, you're not going to load it up and give it have them have a ton of resistance. So versus someone who comes in with, hey, the same SCM patient has come back in, and now after a week or so that they're at a 1 out of 10. All right, then I might do some needling, more spots around the neck, the suboccipitals, the splenius, um, with a different aim, which is let's kind of up ramp some activation and then start to load them more after that. So I kind of come back to this in my head, this chart frequently.
covered this in good detail in the other lectures, but it's, not a bad thing to go through too, just to sort of slowly burn it into our brains, just the mechanisms of, pathophysiology of a myofascial trigger point, and this is more the biochemical environment, and this is just got some studies where they measured, biochemical, mainly directly related to the active trigger points on microdialysis, basically sampling it. And what we see elevated inflammatory mediators. We often think of substance P, calcitonin, gene-related peptides, bradykinin, cytokines, hydrogen ions. These are all things when we have, chemically mediated or irritated inflamed tissues, these are pain drivers in that sense. And what you see in many of these times is these myofascial trigger points is these substances are all elevated within the local tissue. And those of you who like to kind of see the more fancy chart of this with these chemical mediators and how they interact, you're free to kind of. Though this diagram here is great, it goes a little bit beyond my pay scale in interpreting cellular metabolism, but just in the understanding of you know, what happens within these inflammatory mediators, how these chemicals sensitize the system.
Yeah, you can kind of see, all right, hey, there's some hydrogen, there's bradykinins, there's interleukins, tumor necrosing factor. They kind of cross that barrier into the cell, and this is, hey, the end result is you get this increased neuronal excitability, um, and lots of cells are involved with this process, this cascade: T cells, macrophages, mast cells, neutrophils. You get some lymphadenopathy, and then the end result is this neurogenic inflammation that can kick in as well.
And again, you see here that it just talks about just cascade that occurs, to inflame this tissue between elevated hydrogen ions, decreasing the pH, the acidic environment that's created, sensitizing peripheral nociceptors, sensitized nociceptors. This increases the spontaneous electrical activity that occurs with this sustained, spontaneous electrical activity, sustain more sarcomere contraction. With sustained contraction, produces local ischemia. Then ischemia, further metabolites accumulate with a decrease in ATP production. So this is that model that it kind of produces. And that's what they talk about in the sense that vicious cycle that this thing then becomes kind of a self-perpetuating mechanism.
So
Go
this
ahead.
energy crisis model is related there, where hey, there's excessive acetylcholine release at the neuromuscular junction, and this kind of creates some excess potentials in this end plate noise, which then leads to continuous low-level muscle fiber activation. So that sustained sarcomere contraction then increases this ATP demand. As we mentioned above, that the ischemia then decreases ATP supply. So you have increased demand for ATP, but less ATP leads to this energy crisis. Um, Now we're unable to get calcium back into the sarcoplasmic reticulum to stop the contraction, which is one of the rate limiting steps for contractions. As those calcium pumps fail, then you get this persistent actin myosin binding. So then it just kind of cycles there. Hey, the more contraction, the more ischemia, the less ATP. The more contraction, the more ischemia, the less ATP. Until some intervention breaks the pattern. So oftentimes you'll see this knot of this focal area, under these contracting sarcomeres, that taut band, and has this, as we talked about, this twitch response when you stimulate it. So needling is a fantastic way to go in and break this pattern. Certainly, you know, hey, could you do it manually? Certainly, you can maybe use some instrument assisted soft tissue massage. You can beat the heck out of your thumbs working at it for a while. But I like to think, hey, if it's the right patient and there's limited or no contraindications, can we just put a needle in it real quick? And does this break it as opposed to me beating up my knuckles for 15 minutes?
Yeah, it really was the older way, in the old days before dry needling. Certainly, your active release techniques, they still have value today. And I mix them in with the dry needling and some of the manual techniques of releasing. But yeah, it's sometimes a little bit less consistent whether, okay, am I releasing this knot with the deep pressure, or do I create more wind up? And interpreting your patient would wind up. And you may still see the same thing with needling a patient. If I see a patient, I needle them, and I see that they're, it's basically the fight or flight response. I start seeing that they're neurologically winding up, and it's exciting the system. Then I know I need to back down. I need to, okay, fewer needles, more strategic strikes, do a couple and see how it goes. Because if I continue to needle them and I get that neural wind up, certainly with, the descending facilitation that's now occurring, it's kind of counterproductive to what I'm looking for in decreasing a trigger point knot and decreasing the local knot. So I'll be more selective in saying, hey, can I release this knot, to get it to release, and then hopefully unwind that system. Just always be on the lookout. Am I getting the result that I want to see, or do I see that they're actually getting neural windup, which then becomes counterproductive to what you're trying to do? Again, some neurophysiological considerations, spontaneous electrical activity. This is a continuous abnormal electrical activity recorded within the myofascial trigger point. That's kind of sometimes what I believe in it, like you're referring to as far as end plate noise. You see, there's a lot of end plate noise when they look at the electrical activity. After needling, they've shown there's been this decrease in end plate noise and output. And this is what they talk about distinguishing an active trigger point from, normal muscle tissue. Again, similar as as I mentioned earlier, characteristics to miniature end plate potentials with greater amplitude and frequency. And they'll find that this does correlate to pain, severity, and tenderness of the trigger point. So, okay, let's look at a person. Sensitization cascade. Okay, patient cases. That's like a one. There's a 44-year-old, we'll say it's a male with Achilles pain, you know, It was gradual Achilles and gradual Achilles region pain, worse with the loading, palpation, here reviews tender nodules in the medial gastrocnemius. There is local tenderness plus familiar referral into the Achilles region. Critical question. Is this a tendon problem? Is this a trigger point problem? Or is this both kind of contributing to it? And what we can think about this, as I like to do with cases, I think about there's my primary, usually pathoanatomical diagnosis, and then there's my etiologies, those other things which have led to this or contributed to it or have come apart because of it. And, sometimes, it may take a little bit to figure out, okay, what is the key driver of it? So this individual, my thing is, okay, this is Achilles tendinopathy with a medial gastroc, let's say a medial gastroc trigger point. That's what's causing it. So my pathoanatomical diagnosis would be Achilles tendinopathy with an etiology or possible contributor is, tightness within the Achilles or somewhere in the system. Limiting this the big it could be a big scope of things that can be etiologies. We're just limiting this to being the medial gastroc is the one. I think a patient too. We have a 35-year-old with lumbar pain and gluteal pain. You know, they had lumbar radicular symptoms, 3 years ago, which is the radiating, paresthesias down, let's say, into the bottom of the foot. Now the pain is it's more of a somatic or nociceptive pattern that we have. So we don't have that radicular lancinating pain. It's band-like in the lower back with lower back pain and referral into the gluteal region. Trigger point palpation, the lumbar paraspinals and gluteal region, reproduce a familiar pain pattern. What this demonstrates is this person has bit of peripheral sensitization that's probably going on, as well as a segmental contribution at the spinal level, which is being sensitized. In these individuals, this pattern may not be different. We know from Hodge's work that we're probably going to see either inhibited or atrophied lumbar multifidi, and we probably have facilitated upramping of, longissimus iliacostalis with potential referral into the gluteal SI joint region or, secondary trigger points in that region due to the dysfunctional, protective muscular pattern. And here we'll show some of the kind of the classic referral patterns that can be on the right-hand side, looking like from the psoas muscle, as well as ones from the quadratus lumborum. And again, for me, I'm a little different. I look at quadratus lumborum. I think of muscles as being reactive structures to the system around them. So a muscle may be the primary source of pain, but the system is making this muscle do something that it doesn't want to do or isn't well adapted to doing it. So whenever I find a muscle as a primary, my mind immediately switches to why is this muscle being asked to do this job or do more? Usually in phase. Like, is it doing more work when it should be operating? Or is it being asked to work when it shouldn't be operating? So that would be the question I would have when I look at it. Okay, I got a QL tightness. Well, my question then becomes why? Do I have a TL junction rib dysfunction? Do I have a lumbar biomechanical dysfunction? Do I have a hip pelvic dysfunction that's requiring extra stability or an extra moment here? So just good thing to think about as you find this in primary and you're treating muscles, you needle the muscle and they feel great. To really fix their problem, you got to then say, okay, now's my window. What's causing this problem?
Similarly with the psoas, hey, is the psoas always the issue? Certainly in things, you can certainly have some psoas tendinopathy. You can have an abscess behind the psoas, but more often than not, it's the tone of the psoas is upramped to control for some stabilization issue somewhere else. It could be again at the hip. Is there a hip biomechanical dysfunction? Is there a thoracic issue, or TL junction issue as well? So you think about this peripheral cascade, this peripheral sensitization cascade. Um, your primary afferent nociceptors become super responsive to mechanical and chemical stimuli. So again, this is separate from central sensitization. This is at the nociceptor level. You have reduced activation threshold, so it takes much less stimulation to fire off. You have expanded receptive fields, so not, that dorsal horn excitability. You kind of have a larger area around that point of pain that is, sensitive. And you also have, that all leads to this increased response to, suprathreshold stimuli at the segmental and spinal level. So again, you can have some segmental or spinal sensitization. The dorsal horn, the hyperexcitability really drives this, um, and the temporal summation. So um, you're thinking, all right, your body is kind of linking these um, pain inputs in time, and that leads to a bigger kind of wind up in the system. Same thing, you have this expanded receptive field at the spinal level now. So now, hey, all of the levels maybe at L5, you have this big receptive field, and then this descending inhibition issue. Supraspinal, as we went over, I think it was in the second or third week. Um, the central nervous system has an amazing amount of plasticity, both good and bad. With pain and prolonged pain, you see altered pain processing in the thalamus, the somatosensory cortex, the anterior cingulate cortex. And a lot of those places, especially the anterior cingulate cortex, um, ties in with emotional and cognitive influences on pain. And you get this descending modulatory system through the periaqueductal gray and the rostroventromedial medulla as well.
Very good. Motor control dysfunctions. Hodge's research on motor control alterations, it's been 20, he's got, probably 20 to 30 years of research now, in this area. So let's look at patient history. So patient with a history of on and off lumbar pain for 3 years. It started with radicular pain, 3 years ago, and is now in somatic nociceptive. PT, patient number two, patient has gluteal tendinopathy with femoral head centered anterior medially. What we may see with these individuals, both of these individuals, we can expect to see certain things. So with the first patient, the on-off lumbar pain started 3 years ago. Now with somatic nociceptive pain, we know from his research, if they're not properly rehabbed, that will have motor alterations in function. And what you'll often see is that these people have altered function. Can you wait to start that in a little bit? Thanks. They'll have altered motor function based on this. So their aberrant movement strategy is the reason why this person, hey, they're doing great for a little while, then they get reoccurring back pain 6 weeks later, or 6 months later, or a year later. Why we see this reoccurring pain pattern. This individual, it's been shown that, hey, this person does well with some type of motor control program or a strengthening program that goes beyond. And ideally, this individual, you want to get hypertrophy training of the deep system, not just a basic motor control program to get it firing. They find that you really need a hypertrophy program in these individuals. This is where needling comes in. One, facilitate, I can needle and I can use stim as a neural input, maybe in some of the deeper muscles. Certainly down ramping any of the aberrant tone and internal external obliques. You can be looking at that longissimus iliacasalis. It's often commonly going to find a tight fascicle running up to a rib. This can even create a rib or thoracic dysfunction just because of the facilitated fascicle that's running up and attaching to that posterior inferior tubercle of the rib. Certainly in motor patterns, much with gluteal tendinopathy, you'll see the same thing, that you'll see a decrease in femoral head centering. It can be anteriorly or anterior-medially glided, two very common scenarios. With that, you're going to have, basically external rotator facilitation. Also psoas or rectus femoris facilitation is also a common pattern with this hip presentation. So that person comes in, I got tight glutes or their piriformis is achy, think, okay, great, I may end up needling those muscles, but what I'm probably going to also look to do is to correct this underlining and very common finding in this individual. And it goes a long way to kind of cleaning up, the gluteal tendinopathy due to femoral head centering and problems. And that's due to these altered motor patterns. So understanding Hodges and even some of Shirley Sauerman's kind of common motor patterns and dysfunctions that are out there will also help you understand that this is why I'm going to end up needling this muscle. Then also, what do I need to do to correct it?
So you tend to
Timing
have,
deficit. Go ahead, Frank.
yeah. So you tend to have with these timing deficits, especially for that first patient, um, this delayed activation of the deep system. So the multifidi, the transverse abdominis, they take a little bit too long to turn on. At the same time, you have premature activation or even just generalized increased continuous tone of the superficial muscles. So those are rectus spinae, rectus abdominis. You can kind of go even to the rectus femoris with this too. They tend to kind of have this stiff trunk, so you lose this anticipatory postural adjustments. They kind of move in block, and it's a much more stiff system because these global, larger multi-joint muscles are firing all the time and firing a bit early. And then this changes the feed forward control mechanisms that we need to have nice, smooth, controlled movement. So with the muscle stiffness, um, that there's this passive stiffness to those muscles with the myofascial trigger points, and some individuals have measured the viscoelastic properties being altered, um, change in muscle length tension relationships, and reduce force generating capacity. So this deep or this sorry the superficial system, it's being asked to do a whole bunch to stabilize. It's stiff all over, but then at the same time, it's not unable to generate as much force as needed, which is kind of sets the person up for failure if they're asked to do a task at work, like lifting a big box or, in a sport related movement. So fatigability, uh, because of this consistent firing, premature activation of these superficial systems, those muscles with active myofascial trigger points are going to have some premature fatigue. So that ATP, that energy crisis model comes in here, where there's increased energy and ATP demand, but there's decreased supply. So the capacity of that endurance is going to go down, both at the local level and even at the global level. So that this is the patient with maybe some back pain who, he's had back pain for 3 years and got this segmental referral, and he might tell you that he wakes up feeling kind of generally okay, but as the day progresses with work, he just gets absolutely exhausted. He feels like he can't control his body. He feels like his spine. I've had people tell me that they feel like their spine is collapsing in on themselves later in the day. This muscular system is just fatiguing prematurely. You also see altered muscle fiber recruitment patterns. So in the low back in particular, you tend to see, or you tend to want to see in healthy individuals, proximal stabilization happening first before distal motion. So with a straight leg raise task, whether it's supine, side lying, or prone, you tend to see the deep multifidi uh, and the retrospinae turning on before the hip flexors, hip abductors, or hip extensors fire in individuals with low back pain and these myofascial trigger points. That proximal stability does not happen as much. So then all of a sudden you have, you know, uh, a prone straight leg raise. The glute is kicking in without any proximal stabilization. Well, that carries forward into walking. So there's less stabilization up at the spine. And overall, there's just general metabolic inefficiency.
Clinical modifications here. We have, pain adapted movement strategies, protective guarding patterns. You think of this as, technical terms, as a redistribution of activity, within and between muscles. And this pattern happens, it can be with cortical remodeling, it could be guarding mechanisms, certainly increased tone, even just in influences at the spinal segment level. This increasing co-contraction of agonist, antagonist in pairs. I mean, how many times we've seen a shoulder patient here moving, in this aberrant pattern, and it happens so fast when any type of nociceptive input is put into the system. And sometimes that input is, sub-nociceptive, let's say. Let's say we're getting aberrant input from a segment. It can do it. Or you can even think in terms of, okay, do I get decreased input from a segment because I'm not moving a joint properly? So is my proprioception from that joint altered? And that also then creates this milieu of protective or, redistribution of activity, around that area. You know, so reduced movement velocity and amplitude is certainly a big one. We're going to see that with forward flexion or backward bending of the back with aberrant, ratchety type motions when it's not well controlled. You see it certainly in the neck, the shoulder. We see this around, even in the knee and swing speed. We got a little fluid in the knee or a little bit of irritation there. It's enough to change the swing speed and angular velocity of the ankle or hip or knee. Certainly substitution patterns. We're really well adapted to think, okay, I have a limitation somewhere. Your brain goes, okay, next man up and next movement up, and we easily plug in a compensatory pattern to move around it.
I like to think about with patients, these things happen, these substitutions, compensations, and guarding happen for a reason. So evolutionary wise, this increase, hey, if you hurt your shoulder, this increase in stiffness and decrease in activation, it's a protective response. It's hey, we're gonna not move this body part as much in the short term. In the long term, this becomes not as helpful. Because you have an increase in load to other joints, you have decreased movement and particularly decreased movement variability. So this is that common, this person over here on the right, um, is that common kind of neck pain of, Janda's upper cross syndrome, where you have increased upper trapezius activity, decreased deep neck flexor activation, um, tight pectorals, and the weak scapular muscles, rhomboids, mid-lower traps, and serratus anterior. So this is going to lead to, over time, you see this kind of forward head position. It's altering the length tension relationships, putting some stress and strain. So this tight upper trapezius and levator scap, they're now firing all the time. You have this sustained sarcomere contraction. Potentially loading through the cervical spine because of this continuous contraction, where alongside of having that deep neck flexor weakness. So now we have less stabilization anteriorly. The low back,
Mhm.
very similar with lower cross syndrome. We're going to have reduced multifidus activity, but increased erector spinae. And then typically you have increased hip flexor activation and decreased gluteus or your hip extensor um, tone. In the shoulder, we often see, as you mentioned, Dave, these scapular dyskinesias. So quickly, you're going to have altered serratus anterior and trapezius recruitment where
Mhm.
hey, the serratus might drop out a bit, and now the trapezius, especially the upper trapezius, has to kick in more, and then all of a sudden you have this, you know, superior shoulder dyskinesia, just the pure shrug. You have decreased upward rotation, leading to trouble reaching up overhead and doing sports.
Yeah, and certainly even this upper cross, one of the first things I'll do for this is look at the lumbar position.
Hmm.
So, the lumbar position will dictate the upper cross. So many times, okay, hey, let's give them, a chin tucks and other things, but it's not going to decrease the anterior centration of the shoulder, the scapular position. So many of these people, it really starts from foundation up and then looking at the lumbar spine and what's the lumbar spine dysfunction doing in it. So maybe looking at a lumbar patient, you're going to see this upper body position. But when I see this upper body position, I know that I have to kind of somewhere in their daily life and I need to manage the lumbar position. Challenging one will be somebody with more of a fixed kyphosis in that posture type, because then now you're dealing with the cards you were dealt. Because if they are naturally with a kyphotic upper thoracic posture, it's going to push the head forward. They're going to be adapted in that position. So with us, then it's optimizing the muscle endurance and function, within their world. And that's kind of where some of the knocks on postures come in the last, 25 years is saying, hey, posture doesn't always dictate pain. And that is true. But I need to understand the posture when somebody does come in with pain because it can be one of the quickest things I can adjust to decrease length tension relationships of muscles or what a muscle is being asked to do out of phase. So for needling, it becomes very important because we're needling to maybe down ramp pain in a stretched and inhibited upper trapezius. At the same time, we're needling a facilitated levator scapulae to down ramp the irritation that's occurring there. That's not a very common one will do in somebody with a depressed and inferiorly rotated scapula. So for pain, looks like Terrell Simon's model. The patient is 45 years old with lumbar pain, banding pain across the back with heavy lifting, with heavy dumbbells, and 4 days later complains of gluteal pain is what we have. You know, Predictable referral patterns. Here's what we have. Each muscle has its characteristic reproducible referral pattern. You know, Pain typically radiates, within the same myotome or sclerotome is kind of a general standpoint we'll think about. Intensity of the referred pain correlates with myofascial trigger point activity levels. And patient patterns have been meticulously mapped, documented. Terrell and Simons being the kind of the classic model and book that kind of looks at that, as well as others. You
So
know, Good.
so
Clinical
when you
diff.
have someone come in with
Good.
this low back pain, you have to kind of think through the differentiation. All right, what could this be? So, all right, first option is certainly could be some tenderness directly at the myofascial trigger point site. With this, you're going to tend to see more of a sharp focal quality of the pain, and an immediate response to that direct pressure. Um, in this case, above Dave, could you scroll up again to see where this was? This
Sorry.
might be a yeah. Hey, this could be in the one on the right. Is it a maybe a QL or even a rectus spinae, or a glute tendon as well. So hey, you find a trigger point. It's kind of sharp. It's focal. Um, and as soon as you push it, it's causing some things. All right. So the option one is this local pain. Um, can you scroll back down again, Dave?
Sure.
So then this referred pain is going to have it's going to be more at a distance from the myofascial trigger point. So hey, I push on I find that the trigger point, I push on it, and then down the leg, maybe in the thigh, is where I'm feeling pain, as opposed to up at the actual trigger point. You also think through, with this person with the gluteal pain and the banding low back pain. It can also be, that there's a segmental issue, facet joint impairment, biomechanical impairment. Um, you're not typically thinking, a disc or a neuropathic pain because of the quality of his pain at this point. So that referred pain, that the distal to the trigger point, it's going to be after about 5 to 10 seconds of sustained pressure. So hey, you go to push on it, and there might be some discomfort locally, but then after a few seconds, 10 seconds or so, you're going to have this more distal pain. It's typically described as dull aching or deep in quality, and in this case, it feels like their familiar pain. Um, Third option is this radicular pain. So, always think about this in terms of differential diagnosis. I said a minute ago, hey, with this somatic pain, it doesn't really match that, but it's important to think about it. So, this radicular pain follows nerve root distribution, uh, and is going to be in that dermatomal pattern. They may or may not have paresthesias, numbness, or weakness. They're usually going to have positive neural tension signs, whether it's a straight leg raise or an upper limb tension test in the upper quarter. And it's going to be a much, much, much different quality from that myofascial trigger point referred pain.
Just, it's good of a foundational knowledge of referred pain patterns, for myofascial trigger point pain. Really in identifying and treating them. And it's not dissimilar to what we typically see in this pattern. How many people complain of, oh, I've got this pain up in my neck and it radiates down around my shoulder blades and comes through here. And it's more that somatic nature of pain. It's just paying more attention to as we kind of see that, ties that peripheral point back to the more proximal point. But again, also for needling, you may find that, hey, I'm stimulating, some that déqui feeling they'll talk about maybe in acupuncture, that flush feeling. Maybe it is radiating down into the posterior shoulder as you're here needling maybe the levator scapulae. And that's why you'll get those feelings. So being aware of that, hey, that person repeats, hey, I'm feeling this thing here, you know, that's, partly the why. So you're not caught off guard by it. It's nice to be able to kind of rattle off right away, hey, this is kind of what we see. see mechanical effects of needle penetration, tissue level changes, but we have a physiological or a physical disruption of the dysfunctional motor end plates. My mind, this is always very much like, like damaging it, but it's like blowing the circuit breaker in the kitchen. You run the microwave and, to like my dad's house, you run the microwave and turn the dining room lights on, you're going to blow the fuse box. The house is older, so you need to get the LED light bulbs, fix that. But it's blowing the fuse box what happens. Mechanically breaking that taut band or adhesion that we talked about, where you get those sarcomere windup and that tensioning by releasing that area, decreasing the tension in that band is one. Micro trauma inducing localized inflammatory response. I mean this in a beneficial way, and that's where some people, because of the increased blood flow to that area that occurs directly after needling, may feel a flush and a reduction in some of that chemically mediated pain. Sometimes, if we're needling, especially with a pistoning or more maybe a tissue aggressive technique, what we may find is that, okay, because the local trauma, they're going to have a short-term inflammatory response for, 12, 24, maybe 36 hours. But then after then, they start to feel the beneficial response of that washout effect, that decrease in histamine and prostaglandin and substance P, and that reset afterward. So some people, if you're having a little bit more aggressive needling with some pisting those, it's talking to them about what you expect to see over the next 48 hours to set their expectations. Because they're leaving clinic like, man, boy, this muscle's sore in a different way now. I don't necessarily feel better. It's very good to frame the expectations of what you may see. Hey, you may be a little bit sore after this, but hey, the good news is what we expect to see over the next 12 to 36 hours is that this pain should dissipate. And by the time I see you next, you should be, I expect you to be 50% better or 60% better. You know, Creations of micro lesions to stimulate the healing cascade. That's that idea of we're creating micro trauma, increase fibroblast growth factors, increase, basically stimulating a local tissue response for healing. And again, the increased local blood flow to previously ischemic tissue is another big one. And there have been plenty of studies done to show that, okay, the increase in local blood flow that occurs after dry needling with heat map, looking at other different ways of looking at blood flow into that region.
So we talked about previously the local twitch response. Um, but again, it's good to think through this both in terms of, all right, why are we doing this, and also in terms of patient education when it happens. Um, I usually tell them for the first time needler or first time patient being needled, I let them know, hey, as I put this needle in there, you might feel a little twitch, and then I explain, so that this local twitch response is an involuntary transient contraction of the taut band when you put the needle into the trigger point. It's a spinal reflex. It's controlled by afferents from muscle spindles and nociceptors. You're going to see and they're going to feel a fasciculation of the muscle fibers, and it's can often be accompanied by a reproduction of the patient's referred pain. You drop that needle into the rector spinae, and they say, "Oh my gosh, that's it right there. That's the point." Um, from a neural aspect. The needle stimulates these mechanoreceptors and the nociceptors. Those afferent signals travel over those group two and group three. So the alpha, the A beta and A delta fibers, they synapse at the spinal cord level, and then kind of two things happen. One, you kind of goes up to the brain, but also this reflex motor response via the alpha motor neurons comes back down, and you get this transient muscle contraction, which is that visible and palpable twitch. And this is we've talked earlier about that spontaneous electrical activity. This is Hong's integrated hypothesis. Um, so this switch response temporarily resets, throws the circuitry for this dysfunctional motor end plate. We talked about the continuous acetylcholine release. And so, all right, in this diagram on the left is a electrical reading of this muscle. So you see kind of this to the left and right of the big central crest is the spontaneous electrical activity. So even at rest, it's just firing all the time. And then you go through a contraction of this muscle, um, and you see the big increase. But then afterwards, it calms down. It doesn't really calm down. As opposed to on the right, this is looking at, hey, this is again the surface EMG. There's both surface and intramuscular, but you see that, hey, before and after the contraction of this muscle fiber on the right, it's pretty quiet. If you were to zoom in, you'd be able to see a little bit of electrical activity, but in general, it's pretty quiet. Muscle turns on, contracts for a few seconds, relaxes, then it goes back to its baseline. Um, so, needling, as we reduce this spontaneous electrical activation, um, this is going to reduce that excessive acetylcholine release. That then leads to normalizing of this end plate noise. So that end plate noise is another name for that activity up there. You have this disruption, mechanical disruption of this dysfunctional neuromuscular junction. You can restore those normal end plate potential patterns. So clean, quiet, then it fires, then it's clean and quiet again, which improves that neuromuscular transmission efficiency, and it helps with the metabolic fatigue as well. With uh, with Hong's hypothesis, he talks about the decreased contraction, not stiffness. So again, the needle provides this mechanical disruption, which then allows sarcomere lengthening, the release of this sustained actin-myosin bonding, and improved muscle extensibility. As that muscle now relaxes, you then get improved perfusion. The ischemia that was happening, which was decreasing ATP, gets released. So you have improved local blood flow, removal of all those metabolites. They get flushed relatively quickly, hydrogen, bradykinins, etc. You get fresh oxygen and nutrients coming in and improved tissue healing capacity. One thing, patients may ask if you do some needling and they don't feel that twitch response. The twitch response is beneficial, but not required for the therapeutic effect. A little bit similar to how a cavitation with manual therapy is not really required for the therapeutic effect. You can have mechanical and neurophysiological responses without cavitations. Same thing with the twitch response. The intensity of the twitch response does not really predict treatment outcome. Um, and the big thing is you don't need to necessarily chase after them all the time. That their tolerance should really guide you chasing the twitch responses. If you don't get one, and they have low irritability, yeah, you can keep looking for it a little bit because it can be beneficial at resetting things. But if their pain tolerance is low or their irritability is super high, then that might lead to some of that central windup Dave was talking about, and even that some post-treatment soreness. If you absolutely bomb the area with needles, they're
Mhm.
going to have a lot more soreness for a day or two. A lot of us will see this as we go to needling, hands-on needling labs. You're the guinea pig for your partner, and usually the next day or two, all of the muscles that got needled are quite sore.
Yeah. Neurophysiological mechanisms, it's a good thing to do. We covered that in one of the first articles we did in Joel Balaski's article, which has been published twice now. And that's a neurophysiological framework of how needling works. So it is good to know from these two concepts where we really focused on some of the peripheral aspects of it more today, which is great. But I'd go back and revisit just to make sure that, yeah, we're kind of working in both of these systems. So many times that patient, I'm trying to gauge where am I getting my benefit from? Is it this more of a peripherally driven thing? And I need to kind of think in my technique a more peripheral style approach, sometimes more central style approach. And again, I'm not always sure in the first one. It gauges that second visit. Again, that impact, that feedback from the patient helps. I can determine, yeah, I'm getting a stronger, neurophysiological release versus a mechanical release. So patient, 34-year-old male with, that medial gastroc irritation as we're getting back into, biochemical changes in treating this individual would be, reduction in inflammatory mediators in the myofascial trigger point. This is somebody who's going to spend a lot of time bouncing on their calves, so they're going to get facilitated. The medial gastroc head is the one that is typically more facilitated or injured. It's actually called tennis leg if they have a trigger point that kind of goes into spasm or the strain of that muscle. You know, what we see here is by needling, the decrease in substance P, CGRP, bradykinin concentrates, pH normalization. an improved tissue oxygenation. And that's kind of with the trigger point is that release of that chemical binding or that winding of the muscle with that increased blood flow that can almost create a washout effect is what we're looking for. If we're looking centrally now, we see, nociceptive sensitization, reversal, decreased activation threshold of the peripheral nociceptors, reduction of the receptive field expansion that may be occurring for the constant sensitization, and normalization of pain sensitivity. And again, what we commonly see here too is also improved pain pressure thresholds that also occur. Spinal segmental, modulation. Okay. Think of the patient's case, a 47-year-old male, female with a lumbar irritation, with Pilates and yoga. You know, Here what we have is, dry needling stimulates large diameter A beta mechanoreceptive fibers. This activation inhibits nociceptive transmission at the dorsal horn. So this is that segmental influence. We have presynaptic and postsynaptic inhibition also occurring, and this reduced gate opening for nociceptive input. So in this case, we think about needling. This person may be responsive more to that, the classic gate control model at the spinal segmental level. Again, along those lines, you have dorsal horn neuroplasticity, which is decreased hyperexcitability of a wide dynamic range of different neurons. We have reduced temporal summation or neural windup occurring at the dorsal horn. We also get decreased in the central sensitization and normalization of segmental reflexes, where sometimes what you'll find is these individuals may be slightly hyperreflexive. They wouldn't necessarily be spastic. I wouldn't expect to see that, but a hyperreflexia you might see with these individuals. Diffuse noxious inhibitory control. This is more of like a descending inhibition that we see. Noxious stimulus at one site of our body, stimulation, inhibits pain at distal sites. And this is recruitment of descending inhibitory pathways, which is a very common way of modulating pain. And you can also have activation of endogenous opioids. And the endogenous system is probably more of a non-specific system in the sense where other descending inhibitory control may be at the spinal level is involved. But the endogenous system would be more of a general, non-specific pain mechanism. I think in the endogenous system, I think of that person who may get acupuncture and it's relaxing. It's that global response they get from this centrally mediated, more opioinergic response and counter irritation effect.
So finally, from the supraspinal modulation, you have these continuation of the descending inhibitory pathways. So the PAG and the RVM, needling really activates this descending pain inhibitory pathways. The carryover, the release of these endogenous opioids, and as well as serotonergic and noradrenergic modulation leads to an inhibition of the ascending nociceptive transmission. So it blocks the information coming from that altered dorsal horn. And then you think about the limbic system and emotional processing. Again, pain is so linked with emotions and fear in the limbic system in evolution that you see these effects after needling and after manual therapy as well. But you have decreased threat perception and fear avoidance behaviors. This is that classic, maybe chronic low back pain patient who initially just kind of gets in this cycle of not doing much and avoiding and not exposing themselves to potential threatening positions or postures or activities. That, hey, after needling and some pain science education and manual therapy and careful loading and gradual exposure, they're able to then decrease that fear avoidance. You have reduced pain catastrophizing, which again is that, hey, the brain goes right to what could be the worst thing. Hey, if I do this, then the back pain is going to flare up and then it's going to be set back for 5 weeks. This helps to decrease that catastrophizing. improve pain coping strategies. We all have coping strategies, and the limbic system is significantly tied to these coping strategies. And a lot of this is done through the anterior cingulate cortex as well. Cortical reorganization. This is exciting to me. I'm a big dork with this, but it's that the smudging on the MRI that we've talked about in previous lectures. Needling has been shown to normalize the altered cortical representations, reduced cortical smudging in that somatosensory cortex, improving discrimination, um, and then enhancing body awareness and proprioception. So, hey, utilize this tool. And then, as we mentioned before, we then segue into some motor control strategies, even small at first. If the tissue irritability is high, doing small, even single joint at first, small motions to control. It might be, um, even just something as simple as sitting up and doing an anterior and posterior pelvic tilt of their own control. Helps to take advantage of that enhanced awareness and proprioception. The autonomic nervous system, you get this up ramping of the parasympathetic system and down ramping of the sympathetic hyperactivity, improved heart rate variability as a measure of that. You can, a lot of the wearables now will look at heart rate variability and a decreased stress response.
So, mechanism number three, it's a motor system reset. Okay, so we have a 34-year-old runner with, anterior hip pain with running longer distances. Some of the immediate neuromuscular changes that we may see is that the muscle activation and timing, restoring the normal muscle recruitment sequences. So with this anterior hip pain, if we have, let's say, glute inhibition going on as they're lingering later in the stance phase, the femoral head is going to lever into the anterior labrum, into the anterior capsule, potentially facilitating psoas with this individual with anterior hip pain, especially with these longer distance. So that pattern can get stuck within that individual. So restoring the normal muscular recruitment sequences will go a long way many times into reducing the pain pattern, especially in the case here of this runner with anterior hip pain. Improved feed forward posture control. It's a facilitatory mechanism to this, isn't it? Kind of creating general awareness. The needling is a great deal of input to the body it's different than the normal tactile sensation picked up the skin. So how the spinal cord and brain picks that signal up is a little bit more so that enhanced, facilitatory stimulation can sometimes perk up that patient's normal response. So that person there, so if we have, let's say this person has a quadriceps, which has been facilitated with tight trigger points, it's going to change the loading response in early stance. But not only that, like this is a gait cycle we're showing here, but also the swing speed. Because if I have facilitated quadriceps muscle, it's not going to bend when I go to toe off and swing forward. It's going to change the swing speed mechanics that's going on along with it, especially if I have a facilitated segment. If I look at the EMG and the EMG is not there, if it's still on, I have that motor end plate activity when it should be down cycling or off. Now this muscle doesn't get a chance to rest in its normal cycle. And that's going to throw off not only swing speed and normalization of gait, it'll kind of change its antagonist as well. The clinical example, let's look at shoulder dysfunction, pre-dry needling. We have upper trapezius overactivity with reduced lower trapezius and serratus anterior activation. So facilitated upper trap. This may be somebody with an elevated scapula. So it's more pure elevation up, facilitated upper trapezius. Post-dry needling, down ramping upper trapezius tone and probably normalizing it as we do elevation. And the person there with the facilitated upper trapezius overactivity, they tend to be overactive in the last degrees of elevation. Where here, upper trapezius activity should be kind of normalizing or steady. Those individuals tend to try and create that motion with the upper trapezius versus a serratus anterior or lower trapezius force couple. So what we want to see post needling is, hey, can I improve this? Not only down ramp the upper trapezius compensatory pattern, but now does that also then facilitate this lower trap serratus force couple that I can use?
Dave, what are
removing
some
that
things that
inhibition.
what are some things that you would do after needling for this uh, to maybe follow up with some motor retraining?
Me, I really here want to groove a pattern. Like for this individual here, I want to group, especially the end range, that 150 to 180 degrees of motion, because that's where we're going to get that force couple the most common. And I want to make sure as they're doing that, whether it's with tactile cueing, is to make sure that I'm not elevating the upper trapezius tone. The upper trapezius should not be the last pull. I shouldn't see it really going crazy up in the upper portion. It kind of normalizes out and it more stabilizes the scapula in that range, allowing those other muscles to create the motion. And that's going to induce a posterior roll of the clavicle. It should be coupled with extension of the thoracic spine in that position. So I want to make sure I retrain those component motions when I do this. Do they have proper extension of the thoracic spine in that late position? Posterior roll of the ribs. Do I see that facilitation in that last bit of that force couple of the mid trap, lower trap, serratus anterior? This should create that window of opportunity to take out that aberrant muscle firing pattern and then retrain serratus strengthening. Because many times we go in, we muscle test someone like, oh, look, they're weak. And our assessment stops there. We think, oh, they must be weak. Let me get them strong. When really, most of the times, what I'm seeing is inhibition from some other mechanism.
And I think painting it
Folks,
that way to the patient is also, if that's the case, painting it that way to the patient is a positive thing. There's so many people who have been told by a practitioner, "Oh, I'm just weak. I'm weak. I'm weak." When really they're not weak. Like you said, it's a neurological, a neurogenic inhibition. So it's not that they, are flawed or weak or anything. It's just, hey, all right, the system isn't talking to itself. Let's work on that one, waking it up. And hey, after these couple of things, after needling, after a couple of tactile cues, look, now you can, hold this contraction more than you could before. So with that, with the, whether it's shoulder or the hip or the back, we have this length tension relationship restoration. So these trigger points with their sustained sarcomere contraction shorten the muscle resting length. And there's this increased general tone. As the needling releases that taut band, those muscles can return to their optimal length. Um, this really improves the force generating capacity at this new length. And this is something that you need to, I think about doing after needling, or really after any modality, but here needling, let's make sure that they can A, move and B, control, and then eventually C, handle loading and force generation in that new range of motion. And you're going to see, overall enhanced joint range of motion with this. So going back to, PT school, thinking about Sherrington's law of reciprocal inhibition, we have this inhibition facilitation balance. So um, overactive muscles with myofascial trigger points are going to, inhibit the antagonist. So, um, hey, say you have a trigger point in the tricep, well, the bicep's going to be inhibited at that point because the tricep is firing all the time. Um, Needling is going to reduce this hypertonicity and decrease this reciprocal inhibition. So oftentimes you'll see with somebody, um, at a joint, hey, my external rotators are there's a bunch of myofascial trigger points there, um, and as a result, internal rotation is not painful, but it's weak. Um, Doing a modality like dry needling to the external rotators can increase that activation at the of the internal rotators. You have this facilitation of this previously inhibited antagonist and some restored balance. So rotator cuff is a great example for this. Um, Typically you tend to have a lot, and Travell and Simons talk about this, some of this supraspinatus and infraspinatus trigger points that, hey, if you address those, you can restore this balance and then continue on with some motor retraining. A couple other examples would be an upper trapezius trigger point, which inhibits lower trap and serratus anterior, as you mentioned before, Dave. Um, Iliopsoas, we see commonly inhibiting the gluteus maximus. If the hip flexor has increased tone and contraction, the glute max is going to be reciprocally inhibited. And and then pec minor with inhibited lower trap and middle trap. This is that, modern American desk worker driving, using their phone, using their computer. Pec minor, can be have this increased tone and trigger points, which then leads to less activation of the middle and lower trap. And as
Go.
So when I think about needling, this is a big thing in my mind is that needling creates this window of opportunity. I think we've mentioned the phrase a bunch. This window of opportunity for motor retraining. So this immediate neuromuscular neurophysiological changes, they must be reinforced through corrective loading, motor control exercise, and functional training. Without doing this, hey, the patient will feel good for a bit, but if we don't make any changes to the system, then the system's going to revert back. We need to, in effect, reset their thermostat so that they don't go back to the same old thing, or else old patterns will reestablish. So I like to think about a couple things immediately after needling. So in those first 5 minutes, if I'm working this, let me step back for a minute and say that there's some needling that I'll do just at the end of the session that's maybe more pain, there's high irritable patients, some pain relieving things. I'll still go through a smaller version of this. But if we're trying to make some changes with motor control, immediately, first 5 minutes after needling, we're going to do some gentle active range of motion to those new end ranges. We've opened up some end ranges. We're going to do some active range of motion. Oftentimes, I will do some manual facilitation and some feedback. And then maybe 5 to 15 minutes post needling, we're going to really progress these motor control exercises. This is where, hey, your hands-on PNF, your D1, D2s, your rhythmic stabilization, alternating isometrics, and then expanding upon that to get into in the upper extremity, maybe some reaching exercises in the lower extremity. Maybe it's a hinge or a squat pattern that was previously painful. Very, very light, but low load, but heavy on the proprioception in the tactile feedback. And then in that same session, we're going to do some sort of strengthening exercise in this new length tension relationship. So I'll take them to those new points of range, and we're going to do some sort of strengthening in the high irritability patient. It might just be an isometric. In low irritability, hey, it might be some heavy slow resistance training. It might be some lengthening eccentrics. Either way, I'm going to be putting that muscle through some strenuous activity to work on that new length tension relationship. Is there one more bullet point there, Dave? Yeah. So then the final thing is that home program. So I'm going to not just pick whatever exercise come to mind. I'm going to really curate and think about, 1 to 3 things that are going to reinforce corrective patterns. I want them to be easy, low load, and thinking about patterns as opposed to worrying about them having to work out for 20 minutes at home.
All right, just probably a good stopping point for this series. Got to follow on some of the other concepts in future lectures, just getting into the trigger point identification, palpation skills, which we'll get into. So get into more of the case-based stuff, we'll also cover that as well, intermixing some kind of treatment videos in with some of the future selections as we go forward. But this should give you good, I mean, with these lectures, you have a good foundational knowledge on really what the last 30, 40 years of research in trigger point needling I know has involved.
Before you leave.
So on to the next one. So this will kind of complete this lecture and we'll get on to the next one next session.